Hi everyone, hopefully you can see this. So thank you for having me at this year's 19th annual Tata Memorial Hospital Radiotherapy Practicum and Women's Cancer Initiative workshop. This is a virtual presentation. My name is Ben and I am a radiation therapist at 5D Clinics Perth, Western Australia. So my talk will be on SBRT spine at 5D Clinics, of course. And I'll be talking about our accumulated knowledge, any challenges, our experience in planning and delivery. So just a little bit about our clinic. We're pretty young, of just 3 years, but we are comprised of a team of incredible people with lots of experience in SRS and stereotactic body radiation treatment. I have myself over 15 years of radiotherapy experience, half of which have been almost exclusively with the Cyberknife system. Australia has 2 Cyberknife systems. They both happen to be located in Perth, Western Australia, which also happens to be the most isolated city in the Southern Hemisphere. So what do we do at 5D Clinics? We are the only private standalone stereotactic radiosurgery clinic in Australia, for one thing, to exclusively use the Cyberknife M6 to treat a variety of diseases. As you can see in this pie chart, the bulk of our treatments is actually from prostates. However, spines do make up about 12% of the treatment cases. This is just in 2020 to 2021. Here you go. In the smaller pie chart here, you can see that thoracic spines make up the bulk of our treatment plans, with lumbar spines following closely behind. So all patients at 5D Clinics with the opinion of spine stereotactic body radiation treatment must have a consultation with a 5D radiation oncologist. And their case is discussed with the MDT, or the multidisciplinary team. So from there, individual cases are based on their merits and reviewed by the team of radiation oncologists, radiologists, therapists, and physicists to determine if Cyberknife is the best treatment outcome for that patient. And if Cyberknife is not the best treatment outcome for the patient, then he or she is usually referred on to a more appropriate treatment. And if, on the other hand, a patient is approved, then we go forward to having planning scans. So before we go on about planning scans, we need to briefly touch on patient setup, as this will have a large impact on our planning and treatment delivery. As you can see, all our patients are scanned head first and on their backs or supine and on a mattress. However, depending on the target area or site, there may be slight changes. And the whole point is to maximize the potential for the Cyberknife to do its job. For example, for cervical spines, because it's in the neck area, we have our patients immobilized with a thermoplastic mask and with a rigid headrest. For T-spines, anywhere from T2 to L3, our patients are scanned with their arms by sides and close to the body. And for patients with the lumbar or sacral sites, which are mostly in the pelvic region, our patients have their hands high on their chest, and they're scanned as such. And as you know, Cyberknife is a robotic and non-coplanar system, which allows for treatment beams to come from many different angles. 5D Clinics patient setups they prioritize maximizing the number of possible nodes and segments or treatment beam angles, because we want to allow for the most optimized and efficient planning and treatment delivery. So a limitation of the Cyberknife is in its inability to treat PA beams or posterior anterior beams, as the linac is unable to position directly underneath the treatment couch itself, unlike, say, a conventional linac can. So this poses a challenge for posterior targets like spines, for example. Typically, this is usually solved by scanning and treating the patients prone. However, what we found at 5D is that the general discomfort and the slight movements of the patient's back from breathing when the patient is prone, it means it's not really an option for us, as this would compromise the tracking of the Cyberknife. So at 5D, we decided to prioritize stability and comfort above all else. Another question would be the issue with arms, especially for the thoracic spine setups, and then being in the way of treatment beams. Usually an immobilization device would be used to keep the arms above head, something very similar to, say, if you would scan a lung patient. However, what we've found is that this position tends to arch the back and is generally uncomfortable for the patient, so don't use it. And as a general spine treatment, especially for the Cyberknife, can be anywhere on the treatment couch, can be anywhere for 20 to 60 minutes on the treatment bed itself, depending on the complexity of the plan, which can be a long time for a patient to keep their arms above their head or lying on their front or in a prone position. For our planning scans, the primary CT is non-contrast. They're done at 1 millimeter slices. Axial helical is fine. And they need to have a field of view that's large enough to include the skin edge and arms. It's almost always scanned with MRIs, T1, T2 sequences, also at 1 millimeter slices. And it would be preferable to have a PET CT as well. Often helps to delineate the target. So for this presentation, I thought we'll go through a 5D patient case. This is patient A, and go through step by step and discuss the nuances of contouring and collimator selection and techniques and so forth, and tips on how to achieve those constraints. So for this patient, he's a 74-year-old male. He's been diagnosed with metastatic colorectal cancer. In fact, he's had significant treatments to his C-spine, but only to his C-spine. And unfortunately, on a recent follow-up scan, FDG PET, he showed progression to the T7. So for this case, planing scans were ordered. We had a CT, non-contrast 1 mil slice, as explained. We scanned from the middle of the chin to the L1, and we also ordered MRI sequences, T1, T2, at the thoracic 7 spine. And the intent for the RO, radiation oncologist, is to prescribe 24 gray in 3 fractions alternate daily. That means 1 day in between or weekend, if whichever goes first. And obviously to prioritize organs at risk or surrounding organs at risk. So for the Cyberknife M6, we use Precision as our treatment planning system, and we also optimize using Volo. So I've decided to use a thoracic or T-spine case, as they usually are the most difficult to achieve. They have the most organs at risk, and usually they must be optimized in Monte Carlo. In this case, it does need to be optimized in Monte Carlo. And as previously discussed, because this guy was scanned with his arms by sides, it usually means that we're limited in the beam imagery as well. So hopefully it makes for an interesting case study for you guys to have a look at. So on this slide, we have a planning CT, non-contrast with T1 MRI and T2 MRI. And this is how you register CT, T1, T2, register with a small field of view, just to only include the area of treatment. This next slide is the same thing, but I'm doing a PET scan. So instead of going through each slide, I thought it would probably be a bit nicer if we were to open up the treatment plan itself, the Precision, and continue my presentation that way. All right, so just as discussed from the previous slides, what we have here is our T7 patient case, patient A. And like I said before, at the fusion bit, you want to ensure that your box is only looks at the target itself, and then that will help with your MR fusions to be as accurate as possible. My recommendation is that you actually go into the manual fuse, physically move it as close as possible, then go to register, and then hit the rigid image registration. So we're going to imagine that the doctor's already come around and he's drawn the target, the GTV and the PTV, and I have already gone ahead and drawn all the contours. And as you can see, the organs at risk or the contours of interest, well, because it's T7 right here, you can see that you definitely need to draw the heart, definitely need to draw the greater vessels. The esophagus is right next to it, vessels here. And in this particular case, I've also drawn the larger bronchus, but it's not that close to it. It's just more interest only. If you want to, you can also draw the lungs. You can also draw the skin. I haven't done it for this particular case. I just wanted to keep it simple for you. So for the next step, you want to go to spine tracking. And this is where you add a spine tracking volume. Now, the purpose of a spine tracking volume is actually for treatment delivery. Apparently, and according to Accuray, it helps clearing the clutter that isn't relevant for your treatment delivery, which in your case will be the spine, the vertebral body itself, the spinous processes, and the transverse processes and pedicles. So that would be everything outside of that. That's what making a spine tracking volume is supposed to do. What we found is that if you don't have it, it doesn't matter. You can still treat. It's not a big deal. However, if you were to draw your spine tracking volume short and you didn't include the entire vertebral body, that can be a huge problem, okay, when it comes to tracking and for treatment delivery. So my advice for you, if you are thinking about using a spine tracking volume, is either do it quite generously or don't do it at all. So the next step would be going to set up in the machine phase, choose density model, obviously density overrides for anything like artifacts. If you want to force density, for example, the machine itself, 3 fractions, as previously discussed. And in this particular case, I'm going to be demonstrating an MLC collimator head. Treatment anatomy has to be a body, its full part is what we choose, and excite spine is the tracking method. The next important bit is the align. This is the most important bit. You want to ensure that whatever you align, think of it as a pseudo isocenter, it needs to be as close or at the target itself. So in this case, I've actually centered on the vertebral body. If you want to use a shortcut, you can go to VOIs here, double click on TTV right here, and that centers on your target. And then what you can do is you can adjust in your coronal or sagittal until you achieve the best possible aligned mesh, as you can see. And our advice for the mesh is minimum, and this is also Accuray's advice, minimum, try to get 3 vertebrae, try not to have the center in interface. So you can see here that's actually in the bone. You don't want it to be an interface where there's tissue or spinal cord and there's bone. And you also want to try to have like as much anatomy, like spine anatomy as possible. So you don't want to have, for instance, you know, like bits of lung. Okay. So moving on, once you've got your setup and your line all sorted, we're going to the plan. And don't forget the settings in plan. This is very important. So the first bit, that's fine. You can detect heading pixels in CT images. That's what something maybe physics would encourage you to do. But here, this is where you decide where your beams can enter or not. And it's under beam intersection. Now, as I already said to you, this patient has his arms down. So just to demonstrate, I'll put on these contours. What I've drawn are contours like the head inferiorly, and if you can see here, the arms. Because I don't want to treat through arms. What I don't want to treat through arms is because of the uncertainty. So this is inconsistent as you put the patient on the bed every day, and because of that, if we can avoid it, and because there's an air gap as well, we don't want to treat through arms. But we'll allow for up to the armpit and above. And it's entirely up to you, but we find that that is pretty stable in a patient. So if you draw them and you put a intersection that says exit only, it means that beams are allowed to, in this particular case, traverse here and exit through the arms, but they cannot enter through the arms. That's what that means. All right. So moving on, Volo is what we use for to optimize. We used to use sequential, but we don't really have time to go through everything. So for Volo, we're going to start planning, and that's right, I forgot to do something. So very quickly, I'm going to go back into Contour, and I need to assign my targets as targets. So that's done. All right, now if I go back into plan. So before I start filling in the target goals and the critical goals and this whole cost function thing, quickly just have a quick look in the parameters. You can leave them as default. I think they're perfectly fine. I personally like to have this just a little bit lower. This means that I'll allow for a little bit more MU. It won't penalize me as much. This means that I'm asking the computer to give me a few more iterations than 50. This means that, what if I wanted to save time? I'll say, I don't want you to go any more than 300. For an MLC, 300 is a lot. You'll never get 300 unless you've got multiple targets, but we're just doing a single PTV T7 target. These next two things I think are pretty important. They will determine the number of MU per segments or beams. Now, depending on how low you go or how high you go, can create a very efficient plan or a plan that has to use lots of beams to achieve the same result. Okay, but this is very dependent on the plan itself. So you can choose to touch it or not. This one, I have to change that to 10. The reason why is because our physicists don't like very small amounts of MU per beam. So that's the minimum. So going back into goals, we're going to start with PTB7. As discussed before in our slide, this is in centigrade, so it's going to be 24 gray. I'm going to add a PDH goal. I don't want to go above 29 gray. So approximately 1.2 or 120% is our max, and that usually is 28.8, but I'm just putting 29. Same. GTV7, I want a minimum, and usually I like to give my GTVs a nice minimum 3,000. I know this conflicts and contradicts, but it'll be fine. 98%. The next step is to add these shells. So I like to add 4. You can add 3. You can add 2. My advice is that you start simple and you work your way up to complexity. You can choose whatever shell number you like. I choose 2, 15, 30, 60. That's just from experience. That's just something I know from this size, from this target with Monte Carlo and this collimator head, that these shells work for me. Okay, they won't work for every target, every spine, every T-spine. It really depends. I'm going to pop this up 100. I don't have to. Why not? I'm going to put each shell in. All right. And what I'd usually do is, for this particular case, I like to do, the first shell is going to be a prescribed dose. Your second is going to be 50% approximately. Your third's going to be, I reckon, 1/3. The next one is just something under 1/3. Okay. Now you can see we've got, and everything's in high sampling, 84,000 sample points. That's fine. That's actually very low. But I also want to, as you can see in this plan, put goal constraints on all these organs at risk. So what do we need to consider? Well, the organs at risk that we need to consider are as discussed, the heart, the esophagus, the vessels, and spinal cord, obviously, which I should really put on. So if we were to put each one of these individually, the heart, the esophagus, the greater vessels, and spinal cord PRV, you'll notice that, and that we want them high. You'll notice that my sample points have jumped up to 600,000, over 600,000. Now that is very high. What that usually means is that if you were to hit play, each iteration will take a long time. And what this means as well is when you put heart in as a critical goal, it's actually going to go through your entire contour to apply that constraint. So here is my suggestion. Here's my tip for you. Don't do that. So just remember that number, 600,000. Instead, what I would recommend you do is you create a structure that only takes a part of the heart that is closest to the target or the PTV. So let's see how I do that. I remove the contour. Okay. So let's make them. And this is how you do it. Heart plus greater vessels equals, I call them tunes. You don't have to call them tunes. You can call them whatever you like. All right. So what am I doing here? I am creating structures for the esophagus, for the greater vessels, for the heart, and for the spine that is only closest to the PTV at a 30 mil margin or 3 centimeter margin. You don't have to use 30 mils. You can use 50, you can use 20, you can use 15. Just depends on what you're doing. So let's have a look at what this looks like. Just double checking. Yep, looks good. So do you see what I've done here? You see that structure? That's the heart. See the greater vessels. That's your esophagus, and that's within a 30 millimeter field. All right, so with that, let's put those same goals in now. That, and the spine, and the esophagus. And now from 600,000, I've dropped to 140,000. So what does that mean? That means that every iteration, or every time I hit play, it'll be faster. It means that I can hit play more times. That means I can always improve instead of waiting for each iteration to take forever. So just approximately, just because I know the plan off by heart, I'll go back to the spine later. I'm putting 18 because I know that this wants to be 24, so I can probably drop about, this one's quite adjacent, so maybe I'll just put 20 for that. It's not too far from bronchus, won't bother. But for the spine, it's a little bit different. If I remember right, it's 21.9 for max point for TT101, 3 fractions. So let's start with 2000 or 20 gray for max point. Add a volumetric constraint, 1.2 cc. You don't want to be any more than 12.3, so let's do 10. And then just because I've done this enough times, these are my weightings. You don't have to use them. You will find your way. This one's more important. This one's more important. Try 8 for that. And that is your first iteration. So before I hit play, you can choose to do it in pencil beam if you want. But because this is a thoracic spine and it's got lung, you should really be doing it in Monte Carlo. I like to do it in medium 1% because high 1% is a bit too long. Or proceed. When you're ready, hit play, and that is your first iteration of the plan. And just like a cooking show, and just like magic, I have one that I've just prepared earlier. So I'll just briefly go through an example of a plan here. I have a MLC plan. You can tell it's an MLC plan. It's got segments here. And it's very, very tight. I've got all the constraints under, you know, no issues here. It's all very good. And that was probably my second iteration just for this demonstration. This is not deliverable. That means this plan is not ready to go. It's still in medium. If I wanted to finish it, I'd have to put it in high and calculate. But this is just a demonstration. What I'm looking for is I don't want any 30% in the periphery, which I don't have. I don't want doses coming in from the chin or from that port, as you can see. So everything looks very nice. And all in all, I probably would hit play a few more times. If I liked it, I would save it, and we would deliver this treatment plan. Here is the same patient, patient A, but this time in iris, as you can see. The main differences, obviously, for MLC and iris is you actually need to choose your collimations. So you can do it several ways. You can measure it yourself. You can do it in this display. Have a look at it here. Use the measuring tool this side. Oh yeah, it's about 33 in this way, 20 in this way. There's, you know, a couple of small bits. Maybe you want a small collimator as well. Maybe I'll use a 12.5 because that's 11. You can do it that way, or you could just let the computer decide for you. And you can see it's gone for 10 and 30, which is not too different from the measurements we took. I obviously, what did I end up choosing? I chose something higher, went with 15 and 30, and it did a fantastic job. This is a, you know, automatic collimator selection. It's not going to give you the best or optimal collimator selection. Just keep that in mind. Now, this one's quite a simple plan in the sense that there's not too many, you know, different bits that you need to conform around, where you would normally use a mix of collimators. So in that case, I used only 2. Now, if it was quite complicated, I would recommend you use 3, upwards of 3 collimators. So in this one, very similar to the MLC plan, I still had everything under constraints. It's quite a pretty plan. This was, I think I got it on my first try, first iteration. Again, still in medium. If you want it to be deliverable, make sure you put it in high, rescale, make everything nice and tidy. For irises and fix, a tip I would give is, say for instance, you decided to hit your first iteration for 15 and 30 mil coals. I would always look into fine tune, sort by collimator, sort, and do yourself a favor and go through this and have a look and see how many 30s were used and how many 15s. So in this case, the 30 collimators was about 1/5 of the entire plan used. So if I wanted to, I probably could have used a 20 mil coal, or I could have gone the other way and dropped from a 30 to a 25. And the idea is that I want the mix of collimators to be equal, or about 2/3 to 1/3. Usually, if you have very few collimators used for each beans, it means that you've been inefficient with your collimator use. That's how I see it. And that's it. That was planning. So I'll jump out of this and we'll get back to our presentation. Briefly about treatment, if that's all right. I know we're coming up short on time. So for our spine treatment, we choose an appropriate imaging technique, which means that something that obviously you can see on the image. My tip for you is keep the default KV and MA, and then increase incrementally until you have a clear image. Usually, if you need to increase, it's usually for larger patients, but in most cases, you don't tend to have to do any of this. If you have a high uncertainty, I would definitely recommend that you play with your imaging technique. It's perfectly okay to increase or decrease your mesh, the blue grid. In some cases, you may have to increase your mesh at the cost of uncertainty to have a more consistent offset and tracking for numbers. Again, to be at the discretion of the user, of course, and use clinical judgment at all times. For imaging frequency, it would really depend on the target site, the patient, and the confidence of the team and your spine tracking. For example, if you were treating a lumbar spine with the disease localized to the vertebral body, and it was away from organs at risk like bowel and from the spinal cord, I'd be happy with the imaging being spaced far, far apart, 90 seconds upwards. Totally fine with that. And remember, this is a clinic decision. If, however, it was like an intramedullary target or a very, very posterior, that means very adjacent to the spinal cord or the esophagus, I would probably keep my imaging intervals quite short, just to ensure accuracy and for the robot to correct for any slight movements. And that's it. That's the end of my presentation. Thank you so much. I